wonder if I could ask Paula and Chris to come up along with Trish, because I think the other morning speakers have left. We've got about a quarter of an hour just to finish up with a more general discussion. We can take the question discussion in any direction now of all the different topics that have been covered today.
You just got to do like spot stripes and plain.
Right, it's a question over here. David?
Sorry, was just again. My first exposure to this radiotherapy treatment, I found it absolutely fascinating. Particularly interesting for Professor Moore to talk about the evolution of radiotherapy. It's quite remarkable, especially the accuracy with which you can now target tumours, which brings me to the point that on the other side, the clinical side, doctors seem to have difficulty in actually finding tumours still. And they're inclined to say, let's wait till it gets a bit bigger so we can find where it is. Are we neglecting this side of cancer treatment?
Can I sort of get first? This is something
We have one mic
really
up here.
important to understand, and it's the concept that the tumour is somehow a neatly defined ball of cells, like the picture I put up on my first slide, that is self-evident. And what I often have to tell people actually up at the university about this is, I use an analogy. If you have a drop of milk falling towards your cup of tea, you know where the boundaries are. In fact, just as it hits the tea, you have a pretty good idea how it's spreading out. But once it's actually in the body of your tea and it's diffusing and it's spreading out, you then have great difficulty in finding or even thinking of what is a boundary. And we're really, at the moment, asking our clinicians to do something that is almost, I wouldn't say impossible, but certainly very, very challenging. You're asking somebody to find cancer, giving them an X-ray picture. An X-ray picture is just an attenuation map. Or an MR image. An MR image is just a proton map. We don't actually have, even with PET, we don't have something that images cancer where it says that cancer is here. We were looking for physical or functional properties which somehow uniquely define a tumour, and we haven't got there yet. So that is, if you like, you've actually picked the Achilles heel. It's the weak link in the chain, actually trying to define where the tumour is. When we're outlining tumours in our treatment planning systems, I remember a very eminent professor in Manchester back in the early 1980s saying, give me 1 year of funding and I will give you automatic outlining of all breast tumours. We're now in 2012 and we're still reliant on manual expertise, clinical expertise. And there are some ideas of how to help this, but the clinician's always going to be in that loop and make the final decision. We might have machine assistance, but it is a persistent problem. It is a persistent problem. So.
That's also obviously the case with solid tumours. In some ways, with leukemias, it's a little bit more, it's a bit easier because actually then the blood is where the tumour is, and it's relatively easy to sample the blood and find out where the leukemia cells are, or in the bone marrow. But clearly with solid tumours, as you say, it is very much more diffuse. Did you want to
I was going to add, part of the problem is that the cleverer the imaging gets, the more we can see, but that doesn't necessarily mean that it's abnormal. So for instance, I'm a lung cancer doctor. We can now take CT slices through people's lungs, that's salami slicing, at 1 millimetre. If you do that to me, you'll probably find a few little small abnormal areas. So lots of little white bits here and there. Well, what are they? Are they cancers? Almost certainly not. Did I have chickenpox as a child and that's a little scar on the lung? Quite probably. At that moment in time, you've got no idea what that is, and if it doesn't change for the next 2 years, it's not alive and it's not growing. So we can find all sorts of things that are actually completely normal, but it's only the absence of change over time that tells you that. And the other big thing that's been really important in lung cancer is the PET scan that I showed. That does give us valuable additional information because there can be cancers in part of the body that don't show up on the CT scan. but if you do a PET scan, you can find them. So what we used to have, and what we rarely see nowadays, is something called a futile fluorocotomy, which is where a patient with lung cancer would have a major operation to take the lung cancer out of their lung, and then 2 months later it would be clear that they had the cancer in another part of their body. So that big operation with all its side effects could never have cured them because that cancer was there already. Now we find that on the PET scan. So we know at the beginning that unfortunately their cancer has spread. So we can make sure that they're having the right treatment and not having a treatment that they can't benefit from. So things are improving, but unless you're always going to send a surgeon in to take every little bit of something that you find out so that you've got it on a plate and you can look at it and say, yes, that was cancer, no, that wasn't cancer. You're always going to have some areas that just require observation, and therefore only time will tell you whether they're a worry or not.
Can I just have one? I briefly mentioned ICRU, International Commission on Radiological Units, actually systematising the way radiotherapy was done from 1993. And you have this concept in that systematic approach of the gross tumour volume, the bit that you're certain of, and the bit that you're uncertain of, the subclinical spread, where you put a little error margin around it. And then in radiotherapy, if you don't know what movements are, you can't control them, or you can't control your setup errors, then you put another margin around. And so you give yourself some leeway. So really, we're actually targeting something bigger than just what we're sure would be a tumour. So that makes it particularly effective, and that's now done systematically in our treatment planning system.
Okay. There's a question near the back.
Sort of going back to what Trish said about the list of questions in clinics, but also this morning it was mentioned where patients and carers can actually help. I've worked for a long time with late consequences of treatment, both in adults and in children, and I do feel that we should have more of a responsibility to keep asking people, patients, about their late consequences, actually asking them again and again. And I certainly had the experience with my father and another relative at the moment, where they feel that the cancer's gone, so maybe these other small effects are part of what they should expect. They won't tell their doctors, they won't tell their GPs actually about these just little things, but actually they're quite important. And I think maybe we should be encouraging GPs and perhaps the consultants in these annual visits to keep asking the question, do you have a dry mouth for head and neck? Do you have problems with swallowing? Have you got saliva coming back? All these sorts of questions need to be repeated over and over again. Yeah. Not all the way through the pathway, actually, just like giving information, particularly I feel about the consequences of treatment so people can recognise it. It isn't just something you take in at one go, it needs just repetition right the way through the pathway and afterwards as well.
I think that's exactly right. I think the first problem is that it's only relatively recently that we've had large numbers of patients who survive for a long time, and you start to see some of these things. But also, there's now a bit of a shift in terms of the way we think about cancer. So we used to think of cancer as being an acute illness, you were ill for a bit and then you died. Whereas nowadays, A, we can cure far more people, but at what cost? And B, even those we can't cure, we may have lots of different treatment strategies. So we talk about living with your cancer, you might be able to get rid of it, but you might be able to live very well with it. So, even in the 12 years I've been doing lung cancer, we've moved from, well, if your radiotherapy's not worked, sorry, to, lots of different choices, lots of different options. And because of that, what we're actually doing to people, what we're putting them through is becoming a much more important question, which is why the trials that look at quality of life are so important. But there's also the survivorship agenda. The NHS has realised that we've got a big cohort of people who've had treatment for their cancer and may no longer be cancer patients, but still have issues. So we're looking at things very differently. We're asking ourselves, is this sort of come and see us every few months for 5 years and then goodbye and thank you? Is that the right way to be looking after cancer patients, or should should we be doing things differently? And a lot of that is about providing information not just to the patients and their carers in terms of what they should expect, but also to the GPs who, bless them, may not see that many patients with lung cancer. That's all I do all day, every day. But your average GP might have 5 lung cancer patients in practice and see 1 or 2 of them once or twice a year. So how do they know, whether that patient's problem has anything to do with what I did to them? So it's getting that information out there to the GPs, telling them what to look out for, and getting information out to the patients and their families so they know what to expect and they know where to go when they've got problems. And I think that's increasingly important, and I think that's something that is being explored in more detail.
I have actually been involved with the survivorship initiative on the late consequences of treatment work stream, so that's where that question, that comment really came from.
Can I come back to the issue of the patient perspective of getting into trials? And this was touched on just a little while ago. Clearly, with your study with Quartz, there was quite a delay in centres coming on board, and even now there is a lot of variation. I mean, what that implies is that in certain parts of the country, patients are not getting the benefit of going into a trial. Now, I mean, we hear about sending patients to America for treatment. We know that patients, can opt to go to places for different treatments. Should we be allowing patients to know more about trials? Or should we actually be advertising trials? And what's the ethics of that? And allowing patients to almost pick and choose which centre they go to for trials?
I think the ethics of advertising trials is a difficult one, because obviously if you're pharmaceuticals, that drives you very much down one particular drug, for example, or if you're in radiation technology, down one particular maker of radiation technology machines. I think that the emphasis of this particular meeting are actually empowering the clinical population and the patient population and the carers actually with the knowledge and actually with the ability to know what questions to ask and actually to ask them is the way forward. I mean, from the Quartz point of view, the trial looking at brain spread from lung cancer and what's the best way of maintaining best quality of time. The main barriers to centres being involved in that trial, it appears to be probably the clinician's difficulty with being comfortable with a conversation. And the patients themselves, some of them are obviously also uncomfortable with that, but the vast majority are actually quite comfortable having the conversation and having the provision of the opportunity of thinking about being involved in that trial. So that the main barrier is actually we doctors, to be quite honest. So that's another whole tranche of learning that we need to do at the medical school end, all the way up through our professional lives, of actually just being comfortable talking to people about uncertainties. Because uncertainty is at the basis of any clinical trial. If you don't know what's the best treatment to do, you're clearly uncertain. You need to be upfront about that and clear about that, as Trish is saying very clearly. So I think that the way forward is, as the Western Park are doing, and as we're doing at Newcastle, having little strips of paper or adverts on the wall, posters saying, we are active research centre, you will be asked or invited to consider taking part in trials. And just getting it out there, getting it out as part of the normal culture of it. If you've got cancer, you will expect to be offered a trial, and it needs to be in everybody's culture. I mean, it's 12 years that the National Cancer Research Institute initially started, and therefore the National Cancer Research Networks have been in existence. And one of the last slides I showed that 18% of UK cancer patients get partake in cancer trials, and obviously probably 2 to 3 times that were invited, and 18% actually take it out, which is a very impressive number. But as we've already said, the vast majority are in the very relatively easy trials of talking about one drug versus another drug, rather than the quite different arms of trials that we've been alluding to today. Radiotherapy is going to come into its own, and as the UK is a wee bit behind in the radiation technology, but in a way that's fine, so we can learn what works best and what compact machines work best and take that on. But in the meantime, we do need to still be doing the research of saying, okay, technically we can do that, but is that actually providing the best outcomes in terms of quality and duration of time for patients? So I'm not sure I've answered your question at all.
Well, Paula, if we doctors are the barrier, the problem. I mean, is there a role for specialist nurses, research nurses, and maybe radiographers in being in that front line, in sort of explaining to patients, informing patients about trials?
Yeah, very much so, and that's certainly one of the ways that most successful trials are gaining their recruitment, primarily using other colleagues with skills in that, and the time for that. That's the other issue.
Thank you. Time for one last question.
Okay. Could I come back to the imaging question again? Because I just wondered if the thermal imaging can be used to identify areas which need to be looked at in more detail. The sensitivity of these cameras has increased tremendously over recent periods.
I'm aware that thermal imaging is being used, and you're correct. The thing I find quite exciting, although it's not relevant at the moment to external beam therapy, is being able to label cancer cells with centres that basically fluoresce, so you can see where cancer is spread. I don't think we do too much intraoperative therapy in this country, but it is possible if you can identify it, you can either cut it out because you can see it, or you can actually treat it intraoperatively with radiotherapy. Certainly colleagues in Europe are looking at that kind of thing. I'm not sure thermal imaging is going to be too valuable. It's very, very limited. So always going to be
no idea what the
it's going to be
depth
it's just going to be superficial anyhow. Yeah. You can't see deep into the body. That's the major thing.
Okay. So we've got time for one final question then from.
I've probably been taken out slot for admitting to this, but I was invited to take part in a trial when I was a patient and I declined, and the reason was it wasn't made important enough to me. Since I got involved with the NTCRN and I've reviewed patient leaflets, again I find there is an under-emphasis on the benefits to patients. One trial which would remove the need for thyroid cancer patients to have some really unpleasant treatment, but lots of detail about what it wasn't sold.
I think there are two really important things there. I think turning trials down, we always, when we talk to patients about trials, say it's an option and they're allowed to say no. Because at the end of the day, it's a very, very difficult time for patients. They've got a lot to take on, and to then ask them to do that in addition, I'm always surprised when people say yes. It is a big ask at a difficult time for a lot of people. If we all knew what was going to happen to us, and we've read up and researched, it'd be a lot easier, but perhaps not quite so interesting. The other problem with patient information leaflets is we've got to be really careful that we don't oversell something that we haven't proved to be better. And if we oversell one arm of the study, why would you want to go into the other arm? So it's that business of equipoise. Got to be really careful about how we put that in writing and how we talk about that when we're talking patients. And I'm sorry I'm using the same trial again, but the mesothelioma trial that involved the operation, patients would spend time with me who would say, my chemo is really good, I've got great concerns about the operation, it's a big operation. And then they go and see the surgeon and go, those drugs she uses, have an operation. So they might not get that equipoise from me, but they got it from the team. So it's really there's a skill in how you talk to patients about trials. And when we open new trials, our first few patients often say no, and actually at the end of that I sit down and go, well, the way I explain that I think I've said no too. So you have to learn how to convey the benefits of a trial without actually overselling it, frightening people. You've got to be honest, you've got to be realistic. You've also got to explain it in a way that's acceptable to the person in front of you.
I think there's no need to sort of berate yourself, Malcolm. I think research we did a few years ago with breast cancer patients showed that, you know, patients who said no to a trial were sometimes in a situation later on of regretting that, but also patients who had said yes to a trial also regretted their decisions as well. So, you know, we would never question any individual's motivations. Okay, well, look, we've had a very, very thorough day.